All right, good morning, everybody. I'm gonna give the computer long enough time here to screen capture this title slide that I built. And then I'm going to turn my camera on, and I encourage you all to as well, if you are not absolutely Zoom fatigued. These learning community calls are intended to build a community, so it's nice to be able to see each other's faces. And I'll show you mine as soon as I can find the right buttons. There we go. All right. Here I am. Good morning, everybody. It's so nice to see you. People are still trickling in, but I do like to get started on time. I like to set the precedent that all of the value of all of my syllables starts at go time. So for those of you who are new to tobacco cessation or new to my learning community calls, hello, my name is Jim Pavlik. I'm the program, and I say senior because I'm now a senior professional research assistant, or that was my old title at the university. So I'm the senior program and policy analyst, but I'm in fact the only one. So I guess I'm senior, but I have no juniors. I'm the program and policy analyst at the Behavioral Health and Wellness program. So I do a lot of program design and implementation and evaluation. We're a pretty small team, so I get to do a little bit of everything. I split my time here about 50-50 between education and training on the one side and research and evaluation on the other, which sets, if you know my colleague. Hello.
Oh, sorry.
That's okay. If some of you may know my colleague Derek Noland, we have so many things in common biographically, demographically, but on the administrative chart, he sits fully on the public outreach team, whereas I split my time between the two. So the way these normally work, and our TA grant did get extended for the next cycle, so you'll be seeing me for a while now. We're going to go back to the old school version of these. I'm going to start bringing in guest speakers. I hope those are you all. I would love to be able to elevate the work that you're doing and letting you have an opportunity to share that tobacco cessation work to other members of your peer group here around the state. So if you have a success story, if you have successfully implemented a program, if you are currently struggling through a program and just kind of want to talk it through, but you want to talk about your planning process and all the work you did to get that far, I want to know that, and I want you to have this opportunity to share. So reach out to me. I'll put my email up on the screen in just a second. As a matter of fact, before I go too much further along, I do want to go ahead and say some things that the university always wants me to say, and I always forget. I don't have any conflicts of interest to disclose. All of my money right now is STEP money, just like you guys, for the most part. So I'm not funded by Big Pharma or anybody else that's swaying my opinions. And if you don't have it, you can, of course, my email address is exactly like the one seen here, except for it's my name instead of BH Wellness, Jim.Pavlik. Last name is spelled Pavlik. But you can also email that line there, and if I'm not the right person to provide the answer to the question you're asking, somebody there will know who it is. Now I'm going to stop making you look at my slides because the computer has definitely created a nice cover for me, and you can just look at me, and I can look at you a lot easier if I ever do this properly. Okay, so in the future, ideally, going forward, at least every other month or so, I'd like to have a guest speaker up here. So it's not just me all the time. So in order to help me do that, volunteer yourself as a guest speaker. If you volunteer, unless all of you volunteer, I will say yes. I will find a spot for you. In the meantime, I have a couple invitations out to some of my national colleagues to talk about some specific issues. I have an LGBTQ person who's on deck, and I have my colleague Derek Noland on deck because he and I have just recently created a brand new model that we want to make sure that y'all are introduced to. But for today, it's me. So I'm gonna talk about a topic. Yeah, that's okay. I'm gonna talk about a topic that's been hitting our domain a lot lately. It's just sort of over the last, I would say, year or so. Some people have started forming language around and concepts around the idea of what's called opt-in versus opt-out tobacco cessation treatment. It's been around for a while. I have been training opt-out for as long as I've been here. I joined the team in October 2013. We just didn't call it anything. We just called it best practice. But I'm not going to do that first. That's your introduction. I'm going to dangle the carrot a little bit. That's what we're going to talk about. But first, if we can just do a quick round robin, if you can just tell us who you are and where you work, just so that we can all. Some of you may already know each other, but some of you may not. But I'd love to start helping people put some faces to names. So if you can just quickly, if you have video access, turn your camera on and introduce yourself. And I'll do the best I can to like navigate this because there are a lot of us. So I'm gonna do a couple things. Nikita, can we start with you? I'm just gonna go in order of how you appear on my screen. And if I mispronounce y'all's names, you can correct me. I take criticism well.
Can you hear me?
I can.
Okay, beautiful. No, you pronounced it correctly. Yeah. So my name is Nikita. My last name is New. And I pretty much I work with the Pueblo Department of Public Health and Environment, and obviously tobacco. And I am, Melinda Sentence also works with me. And we're basically like the new main points of contact for Pueblo. But we mainly just are working with the separate school districts within it. But yeah.
Great. And then we'll go from there to Amy.
All right. Hi, everyone. My name is Amy Bakoki. I work for San Juan County Public Health in Silverton, Colorado. I am the office manager and I do tobacco prevention cessation work as well with my colleague Becky Joyce, our director.
Great, thank you. Danny?
Yeah, hi, Danny Steen here. I am a community health educator with the New Douglas County Health Department. Tobacco cessation is part of our remit, among other things. And I have to give a shout out to the University of Colorado Health Sciences Center, which is what it was called when I lived there from 1980 to 1990. I started at CU Health Sciences Center as a lab tech, and then graduate school, and then medical school, and moved on to other things from there. So when I was at CU Health Sciences Center in the 80s and 90s, the current Anschutz campus was still Fitzsimmons Army Medical Center, and I actually did rotations in that hospital back in the day. So anyway, couldn't resist throwing that in there.
No, it's great. Have you been to the new building that they built us?
Oh yes, in fact, I've toured the campus and found places that my footprints in the cement in various places and things like that. Rooms that I lived in when I was there on rotations and things like that. So yeah.
Lovely. Well, we're always happy to have you back. Although, of course, I work remotely now, so yeah. I do need to extend that invitation. I'm not there.
Yes, too bad. That's a shame.
I do like it.
Yeah.
Melinda.
All right. Good morning, everyone. As Nikita had mentioned, I work with Nikita, and I'm Melinda Sentence, work for the Pueblo Department of Public Health and Environment here in Pueblo, and also doing tobacco.
Wonderful. Ash, oh gosh, some people got in here in between. Ashley, it keeps moving around.
Hi, I'm Ashley Schollard. I work with Danny actually, so he's right across the hall from me. I work with the Douglas County Public Health Department. I'm a community health educator here, and it's only my 4th week, so I'm still pretty new to everything and completely lost. So
there are so many new faces on this screen right now. You're not alone. For some reason, Amelia, my chat list and my visual list are different. So I don't know if y'all are seeing me skip Amelia. That's because I'm reading the chat. Amelia, can I go back to you?
Sure. Hi, everyone. My name is Amelia Majewski. My pronouns are she, her, hers. I am the tobacco prevention coordinator and also suicide prevention co-coordinator at San Juan Basin Public Health down in Durango, Colorado. So we're La Plata County and Archuleta County. So yeah, that's myself. Thank you.
Lovely. Aisha?
Hi, my name is Aisha. I work in the Northeast Colorado Health Department. We cover 6 counties.
Melissa Smith. I don't know if there's another Melissa on here. There you go.
Hey, there you go. Thank you. Hi, my name is Melissa Smith. I am with Arapahoe County Public Health. I'm one of the community health promotion specialists there and had a history over the last number of years, spent part of that time working in tobacco work, and I'm really glad to be back. Don't have a lot of history on the cessation piece, so I'm really excited to learn more about that and get engaged in that work.
Wonderful. Thank you, Brooke.
Hi, everyone. My name is Brooke Baitolo, she, her pronouns. I am a senior health educator with Larimer County Department of Health and Environment. And Ashley, I feel you have been on for about 7 months now, and I feel like I'm still learning so much. So I feel like we can use this excuse for a while, right?
Oh, yeah. I worked at BHWP for 4 or 5 years before I took over this grant, and it took me a full year to understand this grant. So it's rough. Bev.
So I'm Bev Arill. I work for Chaffee County Public Health, which is Salida and Buena Vista. We have a STEP grant, and I'm one of the few left in the field Baby and Me facilitators.
Wow. I love Baby and Me. Natalie.
Good morning, everyone. Natalie Salcido, Adams County Health Department. Coming from Denver's health department, so you might have seen me, although I'm seeing a lot of new faces, so maybe you don't recognize me. I am the community health promotion manager at Adams County now, in a new role. Was working solely in the tobacco space, mostly, I should say, over the last 5 years at Denver, but now sitting under this umbrella is really the step tobacco work, mental health and behavioral health, substance misuse, communities that care work, and also healthy beverage partnership. You'll hear from some folks who are on the team that are here today. And I don't know that I'll be on these calls often. I wish I could. I will try my best to do that, but I do appreciate the cessation piece. And last year I was fortunate enough to go through the TTS training, the tobacco treatment specialist training, to really understand how that works on the ground, and how we can connect treatment of substance misuse with also treatment of tobacco. So good to be here. Good to see all of you, and thanks.
Great to see you too, Natalie. Daleen.
Good morning. I'm Daylin Colblazer. I work for the Kit Carson County Department of Public Health, and I'm the health promotion specialist in all of our chronic disease programs and our WISE One program, and I teach a safe sitter class. I'm on top of that. So yeah, steps included with all of our chronic disease.
Wonderful. Brittany.
Hi guys, my name is Brittany Lopato. I currently work at the Public Health Agency. I started off initially as the community health worker here. I also took over the tobacco prevention portion of this program in about October. So I'm still pretty new to this this portion of it, but I've been with State County Public Health for about almost a year now. So
Wonderful. Thank you. Jan.
Sorry, I had to unmute. If you heard a big clunk when I got on, that was me spilling my drink. Sorry about that. I'm Jan Spies from the Delta County Health Department. I am the regional coordinator for the West Central Public Health Partnership Tobacco Program. Brand new too, about 2 months.
Yeah, I was just, was it Jolene that preceded you?
Jolene, yes.
So I'm going to say this to Jan, but there's a lot of you I have not sat down and talked with. So you need to schedule calls with me. Jan, you don't have to because you're not technically in the cessation pillar, but you probably should anyway.
Okay.
Raleigh.
Hey everyone, Raleigh Backrack. I'm the Health Promotion Program Administrator with Picken County Public Health and the STEP grantee for Picken, Eagle, and Garfield County.
Thank you. And that goes to Melanie, who I have not talked to in quite a while. I'm anxious to hear an update from you guys too.
Good morning. Melanie Cyphers with Weld County Health Department, and I oversee our A35 tobacco grants, CTC communities that care, child fatality review, grant and our FDA tobacco retail inspection grant. And we are going to be hiring a substance abuse prevention coordinator, also with some opioid funding here in the next month. So yeah, lots of exciting stuff happening in Weld County.
Awesome. Thank you. Rachel.
Hey y'all, Rachel Freeman. I use she, her pronouns. I am the program manager for the Tobacco Education and Prevention Partnership at Boulder County Public Health. Good to see some familiar faces on the call today and a lot of new faces. We also we're not in the cessation pillar in Boulder, so I may not be on these calls that often, but I wanted to pop on, say hello, see some new faces, and yeah, it's good to be with you all.
Thank you. Jennifer.
Hi, I'm Jennifer Lang. I'm a prevention and policy specialist with El Paso County Public Health in Colorado Springs, and working in the tobacco program.
Wonderful. Dana.
Morning, I'm Dana Sobel. I'm with Adams County Health Department. I work on passing sugary beverage policy and then also 50% on the STEP team. Happy to be here.
That's a good combo. Casey. Oh, you're unmuted, Casey.
She's sitting next to me and she says that she is unmuted, but maybe she'll run over to my QB and she can say hello.
Okay. Devin, while Casey's trotting across cubicle space.
Sure. Can you hear me okay?
Yeah.
Okay, perfect. Hi, everyone. I'm Devin Warmer. I'm with Arapahoe County Public Health, and I do full-time tobacco work.
So we have Adams, Douglas, and Arapahoe all here. Fantastic. We thought we might lose the Tri-County representation when we lost the entity, but here you all are. That logging off has created some disturbances on my screen. Keith, welcome.
Morning, everybody. My name is Keith Cooper. I'm the, excuse me, I'm the Tobacco Cessation Intervention Coordinator on the STEP team. I've been with the STEP program since 2015. I've been in this role since last May. So great to see a lot of familiar faces and a lot of new faces as well. If you have quit line related questions, I'm the person you can reach out to. So I'll go ahead and throw my email in the chat as well.
Wonderful. Thank you, Keith. Talia.
Did you say Talia?
I said Talia. Is it the Talia?
No, it's Talia. You're fine.
So close.
It's okay. My name is Talia and I work with the Northeast Colorado Health Department. I am based out of Sterling, but we cover 6 counties. I'm also going to jump on. I know my boss is also on here, Janelle Girk, but she had to take a quick phone call. So she's also in the Sterling office with me as well.
Awesome. Thank you. The Casey, the screen is back to you. Are you in a place where you can say hi or no?
Can you hear me now?
I can.
I don't know why before it wouldn't work, but my name is Casey Pierce and I work in the Weld County Health Department with Melanie in the tobacco prevention program, and my pronouns are she, her.
Thank you. So I went to the second screen and now some people are here and some people aren't. I'll have to go back to the top. Ashley Schollard.
I already introduced myself.
Oh, okay, you
but
did.
I can say hi again. Hi, everyone.
No, I'm sorry. I don't remember saying Ashley out loud, but that's blame that on me. So it did not reshuffle. So we are to Janelle, but she's on a phone call. Halea.
Hello, it's actually Jalea.
Darn it.
It's okay. I'm with Adams County as a youth engagement specialist working with the tobacco team.
Thank you. Becky.
Hi, all. Sorry, I can't turn my camera on right now, but I am Becky and I'm the health promotion and prevention specialist for Summit County government. And I manage the STEP funding and our nicotine tax program funding.
Fantastic. Thank you. And we're going to be talking soon, aren't we, Becky?
We are.
Tracy.
Hello, can you hear me?
Yes, there you are.
Okay, great. Working out my technical issues, but I'm Tracy Guilford, project coordinator with the Tackling Mental on the Black Community Project with the Colorado Black Health Collaborative, and we are a STEP grantee. And so working on focusing, one of the areas is focusing on culturally tailored or focused cessation resources and services for our demographic.
Fantastic.
One question, what is cessation pillar or pillars?
Okay. So, you know what? Let me get through the last two, and then yeah, sure. I'll go ahead and address that. That's an easy question for me to answer, strangely enough. Isaac. And welcome,
folks,
Isaac.
sorry,
I think I've only got to see you once. You went away on fraternity leave, right? Am I making that up?
That was a while ago. Yeah, sorry, I've got barking dogs. I am homesick. A kiddo is homesick, and so it is just one of those special early parenting kind of weeks. I am here in Silver Thread Public Health. That's Mineral and Hinsdale counties. I'm the equity lead and prevention services coordinator, and we're one of the foundational STEP grantees. So lovely to see familiar faces and lots of new faces.
Yeah, fantastic. And Gloria.
Hi, my name is Gloria, and I work with Saguache County Public Health over here in the SLV region. I am the STEP coordinator for Saguache County, have been here since 2019.
Well, fantastic, thank you. So that's Claudia Mercado had to step away for a second, and Janelle had to step away for a second. They can introduce themselves when they come back. We do not do that every single time, so don't be afraid like, oh, I'm going to join 20 minutes late next time because everybody has to say hi. Next time it'll be just the people who've not shown up before. But that's like 90% of today. So that's why we had to do it this way today. All right. So here's what I want. Oh, I'm going to answer this pillar situation. And maybe Keith is actually better to do this. But essentially the way the STEP grant is broken out is that there are certain domains of tobacco use that we can all develop programs in. And you sort of, there are foundational grantees, or what will soon be called previously known as foundational level grantees. Who had not been assigned or did not self-select into a strategy, right? So you weren't necessarily working in schools. You weren't necessarily working in cessation. The rest, everybody else was required to opt into at least one strategy, and those strategies fell into various pillars, of which cessation is one. Keith, is that more or less, did I do that okay? Or would you say something else about what a pillar is?
No, I think that's good. I would just add to, I mean, it's really how our program staff is structured. So we've got our cessation or treatment pillar, which we focus on, quit line services, community promotion of treatment services, health systems change. And then we also have our community and policy pillar, which is where I was formerly housed up until last May. And that focuses on community level, local tobacco control policies like smoke-free, tobacco retail licensing, tobacco-free schools. And so it's really just kind of how our focus is divided up a little bit within the team.
Awesome. Yeah, so I should have using some weird step language. Essentially means that we're talking about cessation. that's what we should talk about it, and that you have a support team of people at STEP, and then of course there are contracted TA providers who can talk about cessation specific stuff, and that's primarily me. All right. So what I'm going to talk about today, and I'm going to call up my notes before I start because that's the responsible thing to do. I want to make sure I hit all my points. There are a couple things I want to talk about, and so I already alluded to this, and that is this newish thing that's showing up in the world that I think that you all should be aware of, and you might be able to use as a prompt as you go out into your communities as a way of altering services, sort of trying to sell this in a new way. Because I said before, I think it's actually older than we're pretending it is. So, and that is this language around opt-in versus opt-out. So let's talk about how tobacco cessation services have historically been provided or offered in the medical setting. So primary care clinics to some degree, but mostly in hospitals, right? This is where we sort of started the sort of proactive-ish outreach to various clients. They would come in for some problem or other, and when they enter the hospital, they would be screened for tobacco use. And hospitals had to start this process back in the late 80s and early 90s, because that's about when hospitals started to go tobacco-free on site. So they wanted to make sure that they were properly responding to patients' needs, because one of the things they learned fairly rapidly after going tobacco-free is that smoking patients being admitted into the hospital would leave against medical advice if their withdrawal symptoms weren't treated. So hospitals began proactively administering the patch. So when I say that opt-in, opt-out is much older than we normally think about it, because it's just now starting to bubble up as a term, it really starts there. It starts in the hospitals in the 80s. Those hospital systems specifically that went tobacco-free prior to statewide mandates to do so. And then, of course, then the statewide mandates made everybody do it. And then it was around that time that we started saying, like, okay, well, we need to treat tobacco withdrawal, or people are going to leave before they get healthy. And so that's what they started doing. They said they would screen for tobacco use and they would literally just give them treatment. They would just give them a patch. And that we're still doing that today. And that's sort of where it's been. Since then, everybody else has sort of adopted sort of a reactive approach. First of all, we don't have universal screening, and I want to talk about that too. But where we are now is, generally speaking, most hospital systems, most primary care clinics have an intake process. People get their vitals done, right? They'll ask, they'll measure their temperature, their weight and height. They'll do their blood pressure, and normally in that time frame, either there or at the administrative level at the front desk, somebody's saying, do you use tobacco? In some fashion, they're screening for tobacco use. Whether or not anything happens after that is really up in the air. And we find that nationwide, about 60–70% of folks are getting screened for tobacco use, which means we should be hitting 100. And so we're failing there, but 60–70% is pretty good. And we're a little higher than that in Colorado. But connection to services after a positive screen is abysmal. It's less than 50% across the board, and in some places dropping down into like the teens. So they're not even getting advice to quit, let alone like a referral to the quit line or a recommendation for pharmacotherapy, et cetera. So this is bad news. And this is largely powered by what is now being called the opt-in approach to tobacco treatment. To the extent that people are getting screened, which again is not universal, if the doctor does the next thing, they'll say something like, are you ready to quit? And if the patient says yes, then they will make a referral to treatment, typically to the quit line. That's normally how that would go. Now, systems are improving, but that is, so I don't want to like throw any system under the bus. So things are getting better, and you can find some places where they're quite good. But in general, that's roughly where we are. Hospitals, primary care clinics are using an opt-in model where whether or not a client is invited to opt in is dependent on their motivation or readiness to quit at the moment they're talking to somebody. We have at BHWP always recommended an opt-out approach, although we just considered it standard of care. Because with every other chronic disease, with every other condition, that's the standard of care. If you go in and you have an arrhythmia, the doctor doesn't say, are you ready to treat your arrhythmia? Yes or no, and then if so, give them a referral to cardiology. What they say is arrhythmia is going to kill you. I'm going to give you a referral to a cardiologist. Boom, that's opt-out. Now, because the person can just not go to the cardiologist, right? There's no cardiology police that's going to haul them into the office. That's what we mean by opt-out. The provider proactively provides the referrals, proactively provides the treatment, and then it's up to the client on whether or not they're going to follow through with that. So the client always has the opportunity to opt out. Now, we've seen opt-in, opt-out in other things too. And some of you might have seen like news stories or personally been involved in like a 501k or a 401(b), 401ca or whatever, like a retirement plan. That's the word I'm trying to get to. And most of those are opt-in. Well, they're changing now too, but back in the old days, a retirement plan, these independent investment retirement-based plans used to all be opt-in. After 6 months on job, you would get a form and then you could fill it out and then your money would start coming out of your paycheck pre-tax. Some organizations have moved into an opt-out model where employees are automatically enrolled into a retirement plan, and then they can always leave after the fact. But there's the administrative burden on either side of that, right? When you're opting in, you have to fill out the paperwork to get into the system. With opt-out, you have to fill out the paperwork to get out. And what we've seen is that in that situation, about 20% of employees, I'm using 2080 here, it's the numbers are not this round, but what we see is that with an opt-in approach, about 20% of employees opt in within the first year of their employment when that's newly offered to them. 80% don't. Whereas the reverse is true if they go to an opt-out procedure. About 80% of the clients or employees stay in, and actually it's closer to 90-something% stay in, and then some smaller number opt out. Typically those who already have a retirement plan, or that maybe through a spouse or partner, or they're just independently wealthy and decided to work anyway, who knows, or just can't afford the investment. So we see very similar numbers when systems adopt these opt-in and opt-out, and we've seen it both ways. There was a hospital system, and actually I learned this story from a webinar that I'll link to in my follow-up email to you all. There was a hospital system that used to use a proactive, that's the terminology they used, a proactive referral system, and they were making 50 quitline referrals per month, and when they moved to opt-in, it dropped down to 5 referrals per month. So they lost 95% of their referrals, or 90% of their referrals. The reverse is also true. So I'm going to use nice round numbers for a Mayo Clinic pilot, which is also described in another webinar that I'll link to you. But they screened about 3,200 people who are coming into the Mayo Clinic for new oncology treatment. About 700 of them smoked. And after they moved to opt out, 300 of those 700 were referred to treatment. 150 made it to their appointment, and 35 completed all those appointments. So even with an opt-out, you're looking at about a 5% completion rate from start to finish. Imagine, which is exactly the opposite of what I just described, right? Well, 10 and 5, smaller numbers. But which is to say that in that particular clinic, within the first 6 months of moving to opt out, I always want to say it the wrong way, within 6 months of moving to opt out, they had seen more patients in that 6 months than they had the entire previous year. Now, why is it important? Well, there's a couple things. Number one is, if you've been to any of our motivational interviewing classes, if you've been through motivational interviewing, if you're coming at this from the behavioral health space, we are very accustomed to talking about meeting clients where they're at. And if a client isn't ready for a certain kind of treatment, then we don't treat it, right? So we really come at this with a sort of default setting that seems like it would lean toward opt-in, right? Be like, oh, do you want to do this? And if not, it's fine, right? So I've been questioning if I did this last month, I was still actually kind of like debating whether or not I wanted to like come down hard on opt-out, come down like hard in favor of opt-out. And the answer is I do now. I've resolved this conflict with myself. I think that one of the things the ways that we've trained tobacco treatment before here at BHWP is we always say, get it on the treatment plan, right? Get it on if they smoke, if they use tobacco, we know that that's influencing their mental health. We know it's causing and exacerbating the depression, that it's undermining their therapeutic medications. We know it's causing the anxiety that they think they're curing with the nicotine, et cetera, et cetera, et cetera. So we always say, get it on the treatment plan. Everybody can benefit from treatment. Now, the question of whether or not they engage in treatment is still the clients. They can go to their case manager. Case manager can read their treatment plan and say, hey, I see that tobacco cessation's on here. Have you done anything about that? Would you like me to connect you to resources? And they can say, I'm not ready yet, right? So this is compatible with meeting clients where they're at, because they're still allowed to opt out. They don't get, those of you in behavioral health who have come from a behavioral health space know that institutions, mental health, community mental health, community behavioral health, they're allowed to fire their clients, right? If a client routinely violates the terms of their treatment plan, and if it becomes disruptive to the institution in some way, that client they can stop serving that client. We're not asking them to do that, right? We're just saying that we want somebody whose job is to routinely return to that client and say, do you want to do this now? Right. And that's sort of the deal. So I do want to talk, I have like one more main point here. Well, I actually had two, I guess two more main points. And one is the language. I say that we've been doing this at least since 2013 when I joined the team. I did not institute a major change in BHWP protocols. It was already in place when I got here. So it could go even further back than that. We've always been saying opt out, just not using those terms. The first time I started hearing the medical establishment where this is, like I said, it's been routinely, the default setting has always been opt-in. The first time I saw a medical established entity, an established medical entity, there we go, advocate for opt-out. And again, they did not use this language, was in 2018. So relatively new. And it came from the American College of Cardiology. They put together a consensus document on what should be the guidelines for treating tobacco use in their settings by their cardiology practitioners. And I'm just going to read briefly what they offer in treatment. This is how full-throated this approach was. And again, they did not use the language opt-in, opt-out. They, in methods, they said, offer treatment and connect to resources. This is the heading, offer treatment and connect to resources. And the description here is the third step is to offer smoking cessation treatment, which translates into providing a pharmacotherapy prescription and actively connecting the patient to behavioral support resources. Under pharmacotherapy, and then it goes on. I'm just hitting the highlights. Under pharmacotherapy, they say pharmacotherapy should be offered to every patient who is willing to accept it, with rare exceptions. And then behavioral support, they say either the clinician or office staff should proactively connect a smoker to his or her preferred form of behavioral health, right? They don't say so, I mean, there is a proactive process that's engaged. The way that Mayo did it is that, and MD Anderson in Texas does it the same way. If you come for new oncology appointments, you are assigned a tobacco treatment specialist. At MD Anderson, you are assigned a tobacco treatment specialist. In Mayo, you are sent to like a tobacco treatment clinic, right? So there are different ways that we can handle this. And if we want to talk about how this might be implemented to different community partners, we can definitely do that. But that's a full-throated support of this opt-out model. It's the first one I ever saw from the medical establishment. This was followed up in May 2020 by the American Thoracic Society, who has similar language and similar recommendations. And then it was shortly after that I saw that ALA is adopting this opt-in, opt-out model. Other people are debating that terminology. Some people are saying active versus reactive. Some people are saying actually the combinations are passive versus active and reactive versus proactive. Or you can just do the BHWP thing and just call it a standard of care and don't give it a name. I don't care. But these are the sorts of terminologies that you will run across as you start to engage in this work. So, welcome to Tobacco Cessation, all of you. We can talk about super in the weeds topics like opt-in, opt-out. All right. So the final point I want to make on this is that there's a real possibility here that this could resolve a lot of health inequities in tobacco cessation. The current so first of all, universality is key. When the hospital systems, when the providers have can provide discretion in who receives different kinds of care, then what we see pretty uniformly is that various demographic buckets get that offer and others don't, or they get it at different rates, right? Which is to say, historically, we know that, for example, people above 65 are offered the advice to quit far less often than every other age group. We know that overweight individuals, people who are by their BMI overweight, right? I'm not trying to make a judgment call, but people who are overweight according to their BMI are less frequently screened for tobacco use or provided the advice to quit, right? In certain systems, we see people who speak other languages are often denied these levels of services because we can talk about rationales, I guess, at a different time, but the general explanatory variable there is potentially a language barrier. If you feel like you have to engage somebody in a conversation and the doctor does not speak that language, then they don't want to accidentally fall into a situation where they then have to call a translator into the office to navigate that situation. But nevertheless, that means that certain demographics are being left out of a very basic and incredibly important screening instrument, let alone the counseling option that should be following it, right? So universality is key here. So we want universal screening. That's our first goal here. We need to get that 70% figure up to 100% of eligible people. I say eligible because some people come into hospitals unconscious and they get an exception. They don't have to be screened right away. And then it's not just universality of screening, now it becomes universality of providing the actual care. Because when we default to readiness or motivation, there seems to be a really good scientific rationale here. So a system that thinks it's being equitable says, okay, well, I'm just going to ask everybody if they're ready to quit without considering why some people may be more ready to quit right now than other people, right? So we talk about intensity of dependence. We talk about who's using, who's not, why they're using, or the availability of care sites, right? So if you are talking to somebody in a clinic and it took them 3 months to schedule this appointment, and it took them 2 hours to get here by bus, and they're like, I would love to see your tobacco treatment specialist, but I can't. And therefore what they say to the doctor in this brief window of time is, I can't do it right now. The doctor says, oh, they're not ready. Right. And so they're saying, I'm making a judgment call of offering this service because they're not ready for it. But what they're really saying is, I need more support to get that level of care. If everybody just got it, we would eliminate the inherent societal inequities in people getting the care or reporting that they're ready or not ready. The care shouldn't be dependent, because it doesn't matter if somebody's ready to quit or not. Let me say it a different way. They're going to die from smoking if they continue to smoke, whether or not they want to quit or not. Their position vis-a-vis their smoking, their tobacco use, does not impact their outcomes, right? So the problem the doctor needs to resolve is the behavior that is tobacco use, right? Readiness to address it is outside the doctor's concern. So they shouldn't be making their clinical calls based off the patient's willingness to do it. Right? The advice is the care. Okay, those are all of my notes on this topic. Do you have thoughts? I welcome them. Feel free to unmute yourself, put your cameras on. What are you thinking initially here?
Are there any legal issues with this?
No. Doctors are largely given a broad swath of what they're allowed to do, and that includes preemptively giving care. Remember, we're not imprisoning people. We're not holding them down and injecting them with nicotine replacement therapy. They still have the option of leaving, but it's almost like when you go into a store and it's a store with like a sales staff. One of the first things they're taught in sales is to put the product in your hand. Right, because it creates a sense of ownership. Oh, I think that tie would look really great on you. Once you feel the material, boom, you're more likely to buy it at that point. So if you already have the referral in your hand, it's already in your system, right? They've already overcome that very first large hurdle. So they're not doing anything. And also bearing in mind, they already do that with literally every other condition. This carve out for opt-in to treatment is exclusive to tobacco use. Good question, though.
I had a question, Jim.
Yeah.
So I know you got a lot of boxes to look at on the screen.
No, your hand appeared over here, so I had to drag you back over here so it didn't look like I was looking away. Sorry, go ahead, Tracy.
No worries. So I heard you make mention when you were describing the process of proactively. So opt out being that doctors are proactively providing tobacco treatment referral to patients that they are seeing. And then I also heard you state that includes providing some pharmacotherapy prescriptions and behavioral support. But then I heard you also state preferred form, that is the preferred form by other patients. So whatever the patient prefers around the behavioral health. I want you to speak about that a little bit more. What does that look like?
Great.
So that was my first question. And then the second is, this opt-in, opt-out, I know the notion of it has been around since the 80s. Are we talking about making it more formalized process now, or I just wanted to get some clarity about where things are at present day with this?
Okay,
in terms of being the process.
Question. So when we can get sort of really weedsy here, but at the highest level, there are 3 forms of evidence-based counseling that tend to be paid for by insurance companies. They are a provision in the ACA. Okay. The ACA says that for an insurance plan to be ACA compliant, they have to provide every single service that is given a grade of A or B by the United States Preventative Services Task Force. And included in there is telephonic counseling, group support, and one-on-one tobacco counseling. So when we say the patient's preferred modality, we're really talking about that level, at that high level. Do they want one-on-one? Do they want group? Or do they want the quit line? And technically speaking, if they have insurance, then that should all be paid for. Those are also paid for I mean, this is all Colorado, so it's also paid for through the Colorado Medicaid office if you are a Medicaid enrollee. And there's only a few exceptions to whether or not an insurer will be paying for it. There are some like small employer carve-outs. There's some plans still exist from like 2009 and earlier, so they've been grandfathered in with provisions that are not suitable to ACA or complying with ACA. But that is largely what we mean, is that they should be providing those options. And then why now? I think it's a really good question. I think it's a couple things, but this is all speculation. I honestly think that it really happened after the American College of Cardiology came out with their document. I think that they really looked at heart disease and cancer, and then within the cancer world, specifically lung cancer, that constitutes almost all the deaths from tobacco. Tobacco causes officially 10 of the top 12 killers, and of course a couple down the line that are super rare and weird, but it causes a lot of different diseases, and that includes 12 different cancers. But 80% of all the tobacco deaths are from smoking, and they are specifically heart disease and lung cancer. So you can imagine that the professional groups in those domains are going to be like very conscientious of what's going on. So I think that they just looked at their data and they said, you know what, I don't know why we're using this approach where we ask if they're ready. When chronic heart disease develops, we just connect them to care. We're just giving them statins. Now they're not shoving pills in people's throats, right? But they are saying, I'm putting a prescription in your file and you can go to the pharmacy and pick it up. Whether the person goes and does that is up to them. And I think they just said, like, we should be standardizing that care across all of these conditions that cause heart disease, and that would include smoking. So I think they did it. And then I think that their sister organization, the Thoracic Society, that's the area that governs the lungs, right? I think they looked at it and said, oh, well, now we're now we're behind. So they came out with their statement 2 years later after a big work group. So they were in the works almost immediately after this 2018 publication. And then I think that this was just such a hard break with the previous default stance within the hospitalist industry that that's when I think, and I could be wrong. I mean, ALA could have been pushing behind the scenes. When I did this in January, ALA had said they were going to show up, but then we postponed it to today, or in December, I mean. But ALA may have been pushing this for a while, and maybe it's just starting to gather steam. So there could be behind the scenes stuff that I'm not aware of. But it looks to me like these two colleges took off, and then the rest are now starting to fall in line. Thanks. Great questions. Thank you, Tracy. I mean, how comfortable do you guys feel like if you were to have this conversation with somebody, like, should we be doing opt-in? Should we be doing opt-out? Like, you're talking to a clinic, you're talking to a dentist in your region. Do you feel comfortable navigating that conversation after just these brief notes, or you're like, not yet? Get some so-sos. Tracy's feeling great. I'm happy to tell doctors what to do. Me too, Tracy. Listen, I'm gonna, ALA did put together 3 webinars, of which the first 2 are excellent. And I don't want to, I'm not throwing Rachel, who introduces these webinars, under the bus. You can listen to her statements during the first one. They give you a nice how to construct the argument of why we should be doing it, but it's all stuff you guys know, right? 500,000 deaths per year, plus 6 times that amount in terms of chronic illnesses that have developed because of tobacco use. She walks through all like the burden of tobacco stuff, and then says, therefore, we should be doing opt-out. And then she hands it over to Mayo. So you can watch that the first time, but you can kind of skip it the second time because it's literally the same exact info. But the first one does a nice case study on what they did at Mayo and the before and after of what it looked like there. And if you're really wanting to say, like, oh, I really want to talk to my hospital systems, and you want to navigate that conversation around like how to implement it inside the electronic health record, he's going to talk about those things there. And it'll give you a sense of what they used. And in my opinion, it's 100 out of 100. It's great language. They clearly had it vetted. I mean, it's Mayo. They're really good at this stuff. They piloted it first, and then they replicated it across, I want to say 7 or 8 other clinics. And then the second one in the ALA series talks about it from a quality improvement standpoint. So if you think that you want to be talking to people who are in the business, of providing medical care or behavioral health care for that matter, about these issues, those are two really great conversations. Unfortunately, you do have to listen to it at normal speed. I prefer to listen to podcasts and webcasts at 1.25 so I can get through them faster. These you'll have to listen to at normal speed. So they're an hour a piece, but if this is interesting to you, then I'd recommend them. The third one is more case studies, but I think you've gotten the bulk of the material out of the first two if you are curious. But I can also answer questions too. I feel really confident about it.
Okay, so you said, are you providing us the links for that, Jim, or?
Yeah, it's
or
one link.
where would-
All 3 webinars are on one page. But yeah, I'll send those out for sure.
Jim, just kind of a quick question. Do we know more about why medical staff have chosen the route of opt-in versus opt-out? Besides, you mentioned sort of the behavioral health lens of meeting people where they're at, but are there other barriers that, I mean, I'm just thinking about how we're simultaneously working to tailor cessation efforts to people who historically have not had access to potentially cessation resources. And so I just draw that connection with, the treatment side and sort of moving people along in that screening process and whether those cessation resources are available. And anyway, just what are those barriers, I guess, ultimately for medical staff that we may know or maybe we don't know and need to kind of learn about?
I think it's all the ones that you're probably used to, Natalie. Like when we have asked doctors historically, like why they do or don't do the 5As, or why they opted into the 2As and R versus the 5As, or why they do or don't offer tobacco cessation counseling, we hear the same things over and over again. First, they'll say, first of all, that's not why they're here, right? They're here because they have influenza that looks like it's going to be developing into pneumonia. They're here because they broke their arm. So why would I talk to them about tobacco? So that's one thing. It's less important than other things that I need to care about. Like I'm a rheumatologist. I have to worry about their rheumatoid arthritis, not their smoking, etc. So there's that. It's the time. They talk about time a lot. The average time of a primary care visit keeps getting smaller every year. When I start, I think it's down to like 7 minutes on average now. That's face-to-face time, and then a lot. They still say like average encounter is like 13 to 15 minutes, but half of that is now taking notes. And so they'll be like, what if they say yes, right? I can't talk to them for 30 minutes. I can't even talk to them for 10 minutes. Like that, the minimum level of talking to somebody is 3 to 10 minutes. And suddenly you're already outside the bounds of the initial encounter. So those are barriers. And honestly, I think that when this all started, tobacco has historically just been given to public health to deal with, not the medical establishment. And we always talk about like not treating tobacco differently, but tobacco for 2 decades was the only addiction that we were asking PCPs to talk to their patients about, right? They weren't, at the time, back in the 80s, they weren't even screening for drinking, right? Over time, they are now screening for lots of what are we now consider behavioral health or mental health conditions. So now they're doing PHQ-9s, screening for depression, they're screening for falls, they're screening for all these sorts of things that were sort of outside the medical establishment's bailiwick. So I think that this is just a system or an outcome of, what do they call it? Just, there's a word for this. I always get it mixed up.
Mission creep.
What's that?
Mission creep.
Not mission creep, the opposite. The word I want is
yeah.
Like it's path dependent. That's what it's path dependent. This is the way we started, so that's just what we keep doing.
Right. But as a physician, I'll just jump in here. Day by day, month by month, week by week, the people who pay for your work are adding this task, that task, the other task,
right? And
that, to physicians, many of them would use that phrase mission creep, because that I'm a gastroenterologist. I'm here to help you with your stomach ulcer, but oh, by the way, we have to ask you about your safety at home.
Right.
We have to ask you about when was the last time you used your seatbelt. And it just keeps adding on, and you're getting providers who are terribly burned out by all
Mhm.
of this, what we would call mission creep. So
Yeah, no. So yeah, I was answering the other side because Natalie's question was, why haven't we why did we always do opt in? Why do we stick with it? Right.
Yeah.
And that's what I mean by like, it was a path dependence. That's how we started. But yes, we do keep that, but that's where the notes are coming from, right? Like you used to be able to spend 30 minutes with a patient, and now providers are saying anywhere between 40 and 70% of their day is administrative work of some kind, notes or other things.
Yes, that is, yeah, that, and the electronic medical record that is supposed to make all of that easier doesn't. And what it does is
Yes.
it promotes a lot of cut and paste.
Mhm.
So we asked you about your smoking 6 months ago, and we cut and pasted in there, and oh, that's already in the chart. We don't
Already
have
in
to
there.
worry about that right now. So
Yeah, Mayo has a mandated, they need a refresh on that particular box every 90 days. If a client hasn't, or if a patient hasn't been in the office for 90 days, they have to redo it. But you bring up a set of strong points. A lot of this can be audit. If you already have the EMR, let's use it for what it's good for, because we can set up automatic triggers so the PCP doesn't have to do any of this stuff, right? Like in a hospital system that's large enough or nuanced enough, like at UC, at the UCH, that is, I'm sorry, we have a tobacco cessation clinic. Denver Health has a tobacco cessation clinic. Certain oncology units have tobacco treatment specialists on staff that aren't not just providers, but they're also managing a tobacco cessation program. And so if that person screens positive for tobacco use, they get the referral automatically, right? And then all we need is somebody to say, you should set up an appointment with your TTS, right? We don't need the PCP to provide a 30-minute intensive tobacco counseling session. Let's send that over to the respiratory therapist or the patient navigator who's a nurse, right? Like there are administrative solutions. I'm not saying there's no time or cost burden. I'm not pie in the sky about this stuff, but we do see cost savings, right? So if you watch those webinars that I talked about, they talk about they saw something like 50 additional clients, and they estimate from those 50 additional clients some amount of quit rates. 28% was their number, which is really good. And from those 28% quits, they got within a year $200,000 worth of savings. That more than paid up for the additional time. With $200,000, you can hire 3 or 4 professionals to take this on, right? Three or four non-MD level professionals to take this on. So yeah, Danny, I'm not here to
no,
say.
you're right on track. You're right on track with that. You're right on track with that. But in terms of barriers, the practical and the logistical, in my mind, is the most important. And if certainly getting primary care providers, that's where I think you get your most bang for your buck, because that is, if you're a primary care provider, that is part of your remit.
That's right.
Is preventive health maintenance. So I know in my own practice, I was an emergency physician. There were a lot of points where we could do preventive health maintenance messaging, but to intervene directly was just not something we could do. We had to get them to their PCPs for that. So anyway.
Yeah. Fantastic points, Danny. Thank you so much for sharing. Excuse me. So we are at time. So we have 2 more minutes. So if you have another question, I'm happy to entertain it. Try to answer it to the best I can. If not, then just a quick reminder that I want to feature you guys instead of me. I'm on camera half my time for somebody. So I don't want it to be me. Although unless I get somebody who wants to do this as a guest speaker, what I'm going to do next time is not going to be a learning community call. It's just going to be a straightforward webinar. That's what I have planned for February, for February. It'll be the 4th Thursday in February, and it's going to be all on nicotine dependence and why we are allowed from a public health community aspect to treat nicotine differently than we treat other drugs of abuse in terms of our policy and general approaches. And I think it supports why we should be moving to opt out as well. I will turn that camera time over and make it a learning community call if somebody here or one of your other peers wants to talk for 10 to 15 minutes about their program. Otherwise, I'm just going to lecture on nicotine dependence. I'm doing this anyway for North Dakota. I'm talking at a conference up there. And so I think it's an important issue and I want to get the word out. Nicotine dependence is almost every tobacco user is nicotine dependent. It's not true of other drugs. So different outcomes means different approaches. Outside of that, the way this normally goes is I end with CDPHE offering updates, but we're not going to do that today. Also, because I think Keith may have left already. All right. Thank you all. We'll talk to you next time.